Good evening, everyone. I hope you are all doing well today. My name is Dr. Noha. I am specialist of Singani at Rostaq Polyclinic. I will speak today about management of vaginal discharge in pregnancy. So, as you see here, a thrush infection symptom. 3 out of 4 women will experience thrush infection at least once in their life. They will be complain of itching, burning, redness, white discharge. So the symptoms sometimes even will be pain during intercourse or burning micturition or thick vaginal discharge. They will describe it as white, cheesy-like material. The cause is sometimes either due to clothing, sometimes the nylon underwear would lead to increased risk of thrush infection, or as you know, uncontrolled diabetic or poor diet who are eating sweet or sugar. Antibiotics, sometimes, for example, the patient went for tooth extraction and the dentist prescribed for her antibiotic will increase risk of thrush infection. Sometimes due to low immunity, stress itself can lead to thrush, pregnancy itself, and hormonal changes or even COC can lead to increased thrush or candidiasis. What about the prevention? The prevention, as you know, everyone should be observe personal hygiene, less sugar and alcohol, eat more fruit and vegetable, and sour milk product, and to avoid nylon underwear. So again, we have vaginal infection either in the form of candidiasis, fungal, or bacterial, or protozoal. So here we'll speak about vaginal or vulvovaginal candidiasis. Either it is Candida albicans, which is 80 to 89%, or non-Candida albicans. The risk factor, we mentioned it before. The symptom, we also mentioned it before. The sign, also, sometimes there's erythema, fissuring. The discharge will be non-offensive and girthy, but maybe thin or absent. Sometimes we'll see satellite lesion and excoriation mark. The diagnosis sometimes is by inspection. You'll see whitish vaginal discharge, and it's preferred to do also vaginal swab, but not necessary to do vaginal swab for candidiasis. It's clear by inspection. And again, we have to do rundown blood sugar or glycosylated hemoglobin. We have to do also iron level because sometimes iron deficiency anemia lead to increased risk of candidiasis, or sometimes serum ferritin, not necessarily iron, but we do ferritin to know if she has iron deficiency anemia. In this case, there's risk of candidiasis. So the treatment, if she is, for example, unmarried, you can prescribe fluconazole capsule 150 a single dose. Or if it's just married, you can prescribe for her clotrimazole bizarre a single dose. If severe, sometimes there are severe that you can find excoriation, she couldn't sleep, you can give her fluconazole 150 milligram stat and repeat it day 4, so 2 doses. What about recurrent? Recurrent means more than 4 times per year. So here the treatment would be fluconazole 150 milligram orally every 3 days, 3 doses. Then maintenance will be 150 orally once a week for 6 months. What I mean by that, for example, I will give her 150 on Sunday, then after 3 days, you will see on Wednesday, and again on Sunday, Wednesday, Sunday, Wednesday, means 3 doses. After that, you will give fluconazole every week for 6 months. Sometimes there are not respond to either fluconazole or clotrimazole, so sometimes this is non-albicans candidiasis. Unfortunately, vaginal swab, when we are taking, it will not show whether it is alpican or non-alpican. So in these cases, we will give nystatin pizarese 100,000 intravaginally for 12 to 14 consecutive nights. This is if there's no response to fluconazole or clotrimazole. That means this is non-alpican candid species or azole resistance. What about the pregnancy? In pregnancy, we can't give any oral therapy. It's better to be avoided in pregnancy. Here we give clotrimazole pizarri 500 intravaginal at night for 7 consecutive nights. What about recurrent? As I mentioned, it is 4 episodes per 12 months per year. So in this case, we'll start giving clotrimazole and increase instead of 7 days, we can give for 2 weeks according to the symptom response, and then we can give every week one suppository till full remission. Do we need to contact tracing? No, not required at all. And the follow-up, of course, to see if there's response or not. And as I mentioned, if not response, that might be due to non-albican species. So again, this is just a chart of the treatment. We say if acute or recurrent, what to do. For example, we say if acute, we can, if unmarried, we can give fluconazole or clotrimazole suppositories. If recurrent, as we say, how to give the fluconazole, we can mention, as I say, day 1 and day 4 for 3 doses, then weekly for 6 months. And if pregnancy, of course, we can't give this oral, we will give clotrimazole suppositories. And if no response, we can give 100,000 nystatin for 2 weeks. What about boric? Sometimes if there is resistance to nystatin, we can give 600 milligram boric acid, but boric acid, again, not to be given in pregnancy. And sometimes we have to put in other mind, other differential diagnosis if there is no response. But most of the cases respond well to these medication. So again, this is only the another resource of the same management. And this is very nice. I found it in RCOG guideline. They say the duration of therapy, longer courses are recommended in pregnancy because, as we say, pregnancy is a risk factor of candidiasis. So here, there's a systemic review found that 4-day course will cure just over 50, whereas 7-day course cure over 90%. So many of us are giving only 1 dose. Clotrimazole substitute is only 1 dose, but it's better to give at least 4 course, and it's daily, means consecutive you will give, not only every week, because this is what they found the medication in pregnancy. So we'll give 7-day course of clotrimazole substitutes in pregnancy because this will cure over 90%. What about bacterial vaginosis? For bacterial vaginosis, many have smell like fish, and the risk factor because many are using vaginal douching, sometimes in black rays or recent change of sex partner, smoking, or other sexual transmitted disease like chlamydia or herpes will increase risk of bacterial vaginosis. And you know the bacterial vaginosis in pregnancy is the main infection that can lead to preterm labor. So what are the investigation? We'll do vaginal swab, but of course the result will come only bacterial. Will not show you exactly bacterial vaginosis, but according to the sign and symptom and from the history, you can give either clindamycin cream for 7 days or metronidazole. We have 250, so you give 500 milligram for 5 days. What about Trichomonas vaginalis? Trichomonas vaginalis, you know, this is the causative agent is Trichomonas, is like a protozoa. So here we'll give metronidazole 500 BID for 5 to 7 days. Of course, here also they will have like offensive odor, lower abdominal pain. They will complain of dysuria. Here you will see also vaginal discharge and strawberry cervix, and it's associated also with the preterm labor and low birth weight, postpartum sepsis. So here to give metronidazole, many will ask whether metronidazole, which is non-biflageal, is safe during all stages of pregnancy. You can give in first or second or third pregnancy. It's just one note that regarding flagyl in patients who are breastfeeding, it's advised to discontinue breastfeeding for 12 hours to reduce infant's exposure. So it is safe in all trimester during pregnancy, but in breastfeeding, it's preferable to avoid metronidazole, or if you give the metronidazole, advise the women to discontinue breastfeeding at least 12 hours. And what about genital herpes in pregnancy? As you know here, genital herpes can lead to neonatal transmission, especially if primary herpes 41, recurrent herpes 3%. So here we can give acyclovir or fasciclovir. All these are safe in pregnancy. In all trimester can be given. Whether it is primary or secondary, the treatment will be acyclovir. So here, this is a study from Canada. They found it is safe in both a pregnancy. It's considered as category B. What about chlamydia trachomatis? Of course, also vaginal swab will not show us the chlamydia, but it should be done specific test called NAT. And in general, the patient would complain of vaginal discharge, postcoital bleeding, intermenstrual bleeding. So any woman in reproductive age group, and she complained of intermenstrual bleeding or postcoital bleeding or dyspareunia, put in mind this is chlamydia trachomonas. So here it's better to, if she is not pregnant, you can give doxycycline. But this is doxycycline is contraindicated in pregnancy. So what we'll give in pregnancy, azithromycin can be given. Giving 1 gram orally as a single dose, followed by 500 once daily for 2 days. Also, we can give erythromycin and amoxicillin. So, doxycycline or fluoxetine are contraindicated in pregnancy. It can be given to non-pregnant women. In pregnancy, we can give azithromycin starting 1 gram orally as single dose. Then 500 once daily for 2 days. And of course, we have to contact tracing and also do full sexual transmitted infection investigation like HIV, hepatitis B, hepatitis C, and syphilis. Sometimes if it's not available azithromycin, you can give amoxicillin 500 3 times per day for 7 days. But the response to azithromycin is better. What about gonorrhea? Gonorrhea, we can give ceftriaxone injection, single dose. And if it's not available injection, you can give cefixime 400 oral as single dose. Unfortunately, cefixime is not available in our polyclinic. So you can prescribe for her from outside as it's only single dose 400 milligram. And sometimes while we are doing vaginal swab, we found what is called group B Streptococcus GBS. Please, this is very, very, very important in a pregnancy. If we have any patient with group B Streptococcus, write this in a green card because we should offer intravenous antibiotic in labor to avoid meningitis to the baby. And sometimes we give a treatment if it is GBS in urine. It's not only in vaginal swab. Sometimes come like the causes of UTI, GBS. So this is very high risk pregnant women because we have to give her antibiotic to treat the UTI according to the culture. In addition, we have to give her intravenous antibiotic prophylaxis and labor, which is penicillin. So this is the reference that I used for this lecture. If you have any question, you are welcome to ask anytime. Thank you very much for your listening.